Welcome to a new episode of the Diabetes University. This is your host, Dr. Y. In this episode, we will talk about hemoglobin A1c, what it is and how we can use it in diagnosis and management of diabetes. Let's start with a case study. This is an actual case, but all the name and identifying information have been changed. The only thing that remains of the case are the clinical results, the numbers, the hemoglobin A1c numbers, and the sugar numbers, blood pressure, and vitals. But all identifying criteria have been changed in accordance with HIPAA law. Deborah, not her real name, is a 37-year-old African-American female patient referred for evaluation and management of hyperglycemia and possible diabetes. The cause of concern was a hemoglobin A1c that falls outside of the range on that lab. The range on the lab was 4 to 6% and her A1c was 6.1%. It was checked in May of 2019 and repeat result in June of 2019 was also 6.1%. The patient had fasting glucose 83 on the same lab draw. She does not have family history of diabetes and did not get gestational diabetes with her 3 previous pregnancies in 2007, 2009, and 2011. Patient has been complaining of fatigue with hair loss, but she denies polyuria, polydipsia, or weight loss. Her weight is 198 pounds, BMI is 38.6, which puts her in the obesity category, blood pressure 101/68, heart rate 66 per minute. Examination was normal, total cholesterol was 136 milligram per deciliter. So the next best step in management is 1. Recommend diet, exercise, checking fingerstick glucose. 2. Recommend diet, exercise, checking fingerstick glucose, and start metformin therapy. Number 3 would be going all in. Recommend diet, exercise, checking fingerstick glucose, start metformin, statin, and ACE inhibitor. Number 4, order glucose tolerance test and iron studies. And number 5, order C-reactive protein, complete lipid profile by NMR, and a CT cardiac score. Now there are 2 ways to manage or to address this question. The first one is simply from test-taking standpoint, and some of you might be either fellows or medical students wanting to know how to improve your score on multiple choice questions. Well, here is a tip for you, is that when given the choice in a case between learning more information about the patient and doing an active management, always go for learning more information about the patient, because we need to diagnose before we treat. Now, of the recommendations written, number 1, 2, and 3 are actually active management criteria or active management recommendations, but number 4 and number 5 give you more information about the case, so they are more likely to be correct. Now, between 4 and 5, which one do you think is more correct? Number 5 aims at cardiovascular study of the patient, but that would be completely missing the point of why the patient was referred and what the concern in the case is. Number 5 would be the evaluation if a person has high cholesterol or abnormal lipid panel, and the referral was for that. But if we are focused on glucose and wanting to diagnose diabetes or know if the patient falls within the diabetes spectrum, then we need to order a glucose tolerance test, and I'll show you why in a second. We need also iron studies. Accordingly, I chose option number 4, and that is the correct answer. And we will see in a minute why iron studies are important in this particular case. So what is hemoglobin A1c? Well, before we understand what is hemoglobin A1c, we need to find out what is hemoglobin. Now, the red blood cell, which carries oxygen in the blood, has a molecule called hemoglobin. That hemoglobin is what gives the red cell the color red. Glucose attaches to that hemoglobin and forms a very strong bond, and it's called hemoglobin A1c. Now, that percentage of hemoglobin A1c in relationship to the total hemoglobin is what we are after. That's why when you see hemoglobin A1c, it's always expressed in terms of percentage, 7%, 8%, and so forth. What's the percentage of? Again, it is the percentage of that hemoglobin A1c, glycated hemoglobin, compared to the total number of hemoglobin. So it follows that the higher the blood glucose levels are, the more glucose will get attached to hemoglobin, and the higher will be the hemoglobin A1c percentage. For example, if the hemoglobin A1c is 7%, that means the average or mean blood glucose values over the last 2 to 3 months were around 150. But if the hemoglobin A1c is 10%, well, that means the mean blood glucose over the last 2 to 3 months has been around 250. Now, hemoglobin A1c is very important for the following reason. You see here that the sugar molecule likes hemoglobin very much, and they form an indestructible bond that lasts for the lifespan of the red blood cell. Because the red blood cell has a lifespan on average of 120 days, that means the glycated hemoglobin reflects glucose control and glucose levels over the preceding 2 to 3 months. Now that is an important piece of information, but also it should make us think about the question, what if the lifespan of the red blood cell is not 120 days? What if the lifespan of the RBC is more or less than 120 days? Does that affect the hemoglobin A1c? The answer is yes. This slide shows us that there are many factors affecting hemoglobin A1c beside blood glucose levels. One such prominent effect comes from the change in the red blood cell lifespan. A common condition is iron deficiency anemia. Patients who have iron deficiency anemia will have an increase in survival of the RBC, and therefore their hemoglobin A1c will be artificially high. Conversely, if someone had an acute blood loss within the last 3 months, obviously this lowers the lifespan of the RBC, and as a result, it will make the A1c artificially low. There are also other mechanisms of affecting the hemoglobin A1c, such as assay-related artifacts. Some prominent ones include aspirin, cigarette smoking, and the renal disease that produces an artificial increase in the hemoglobin A1c. In clinical practice, there are some common conditions that result in an inappropriately low hemoglobin A1c, and some others that result in an inappropriately high A1c. we need to be familiar at least with the most common ones. Some of the most common ones that result in an inappropriately low hemoglobin A1c include hemolysis, certain hemoglobinopathies, recent blood transfusion, and acute blood loss. Some, on the other hand, that result in an inappropriately high A1c include iron deficiency and vitamin B12 deficiency. These are things that we see quite frequently. So what ended up happening in this case? As we said, we chose to do a 2-hour glucose tolerance test, and we did, and here are the results. The baseline was 90 milligrams per deciliter, 1-hour glucose was 139, and 2-hour glucose 122. None of these figures falls anywhere close to diagnosis of diabetes or prediabetes. On the other hand, the iron studies showed the iron level to be low, iron binding capacity to be relatively high, iron saturation low, and the hemoglobin was borderline low. The reason I suspected the patient might have iron deficiency is because of her symptoms of fatigue and hair loss, two prominent symptoms of iron deficiency. So basically, in this case, the diagnosis is iron deficiency anemia. The patient has normal glucose. She does not have diabetes or prediabetes. The question, though, is why was hemoglobin A1c higher than expected? There are three answers. The first one is iron deficiency anemia. As we saw, iron deficiency will increase the lifespan of the red blood cell and as a result will relatively and falsely increase hemoglobin A1c. The second answer is that hemoglobin A1c level tends to be slightly higher in African American population, but that does not indicate higher glucose levels. It is just a benign finding without any negative consequences. Number three is that the range established as normal for the A1c test between 4 and 6% is based on older criteria. Back in 2012, the ADA considered anything above 6% for A1c to be prediabetes. In 2015, they changed this to become anything higher than 5.7%. But regardless, we need to be familiar with what is the range for. Is it for diagnosis of diabetes or is it for just glucose abnormalities in general? Improvement of the patient occurred symptomatically on iron therapy with the level of energy and with hair health, and dietary recommendations were given to avoid future development of type 2 diabetes. Now, why did we have to give any dietary recommendation since the patient does not have diabetes or prediabetes? Just because of the BMI that is elevated and that puts the patient at risk for future development of diabetes. But she does not have to check finger stick or do any kind of medication for either diabetes or prediabetes. Now that takes us to an important lesson about surrogate markers. If you remember, in the introduction video, I told you that from time to time I'd be making comments about some cardinal rules of medicine that should help us in our daily practice. Now, one of these rules is here. Surrogate markers are donkeys. But what are surrogate markers to begin with? Surrogate markers are indicators of a state of disease. They could be blood tests or otherwise, but in any case, They are not important for themselves, but because they indicate a state of disease in the human body. For example, T-score on a bone density is used to tell us whether a person has osteopenia or osteoporosis. LDL on a lipid panel blood test helps to tell us what the amount of bad cholesterol in the blood is, and that is used to tell us about the state of cardiovascular health for that person. Here, the hemoglobin A1c is used to tell us on the state of glucose levels and diabetes for a person. However, all surrogate markers are limited. They are limited in what they can tell us. They are an important piece of the puzzle, but they should not be used in exclusion for other clinical criteria, because if we do, we can end up making the wrong diagnosis. Why did I choose donkeys to represent them? It's because a favorite author of mine called Dostoevsky, in one of his books, a character tells another character that a donkey will collapse under its weight even if that weight is made of precious stones. Now think about that. If you are a donkey and you are carrying a heavy weight, it doesn't matter to you whether that weight is made of grass or made of gold. All that you care about is that the weight is too heavy. In similar fashion, the hemoglobin A1c, if burdened by too much, if we rely on it too much, it will collapse occasionally under that weight and may mislead us. So why has there been such a reliance on hemoglobin A1c? It is because it is an easy test that can be done even by a finger stick to tell us some information about the state of diabetes control. But just because we can do it quickly and it's an easy test should not rely too much, should not make us rely too much on it, but we always have to be careful. Take-home points include the following. Hemoglobin A1c is an important test for evaluation of overall glucose control, but it has many limitations and should not be used to the exclusion of other indicators. Multiple factors affect hemoglobin A1c other than average glucose levels, and these factors need to be taken into consideration. Avoid overinterpretation of surrogate markers. There are some other tests that can be used to diagnose and to evaluate the diabetes management, and we will talk about them in the next episode.